Good evening, and welcome to the Blavatnik School of Government for our first public lecture of the term. My name is Martin Williams. I'm an associate professor of public management here in the school and also a research fellow at Green Templeton College. And so it's my pleasure to be convening this presentation, one of several launches for the Lancet Commission on high quality health systems in global health. It's a bit of a tongue twister, especially because we're co-sponsoring this event with the Oxford Global Health and Care Quality Initiative. Did I get it? No, sorry, Oxford Global Health and Care Systems Initiative. So systems in this one, but not in the initiative, which is a new initiative headed by Mike English, among other people, which is trying to link up a lot of the work that's being done across Oxford University on health delivery, healthcare systems, quality of care, and various other permutations of those words. So if you are someone who works on those kind of topics, then please come and find Mike. They're very interested in getting to meet you and publicizing your work and making connections. It's a real pleasure to have Margaret Kruk here tonight, and thank you all for coming out as well. This talk was quite oversubscribed, and we also have a number of people joining us via webcast. So I'm going to introduce Mike in a moment to introduce Margaret, but in terms of outline of the evening, Margaret's going to speak for about an hour, and then there will be half an hour for questions at the end of that. When we get there, we do need you to wait for the microphone in order to ask the questions so that our online people joining us can also hear the question. But let me, without much further ado, hand over to Professor Mike English, who's professor of child health, no care, no quality, just professor of child health here at Oxford University and a research fellow at Green Templeton College also.
Thanks very much, Martin, and it's a pleasure to be here, and thanks to the Blavatnik School for hosting this. And so the Oxford Global Health and Care Systems Initiative, it will soon be led by others, including Nick Fahy, who is here. So the idea is basically to try and begin to showcase across Oxford what is happening with regard to health systems, and not just in low middle income countries. There's a very strong interest clearly in both the UK and European systems, but that's another story. What we're here for tonight is to welcome Margaret Kruk, who's already had to go through several hours talking with us and arrived on the plane this morning from the US, but it's a real pleasure to have Margaret here. Margaret is Associate Professor of Global Health at the Harvard T.H School of Public Health, which I'm sure you're all familiar with, and has done work in multiple countries over quite some time, in Africa, perhaps to a lesser extent in Asia. But it's great to have her here, and more particularly, Margaret, over the last couple of years, has led this Lancet Global Health Commission and drawn it together and produced I think what will be a very influential, at least I hope will be a very influential commission report that was published about a month ago. And for those of you who haven't seen it, then the simplest thing to do, I think you can see in the bottom of Margaret's slide, is HQSS. If you just Google HQSS and commission, you'll just get to the website and you can download the report and multiple accompanying documents. Anyway, it's a great pleasure to have Margaret here, and I'll pass over to her. And as I say, Margaret will go through her talk and then we'll take questions at the end. So, Margaret, thank you very much for coming, and great to have you here.
Thank you very much. Hi, everyone. I'm Margaret Kruk, and I'm really thrilled to be with you today. This is the first time we're talking about this commission and these findings in the UK. Tomorrow we'll be having a satellite session at the Liverpool Health Systems Research Meeting. So you are the test audience here. And I do have a lot of slides and a lot of findings to share, but I also am fine if someone just has a burning question and a clarification, please just wave your hand. I'd be happy to pause at any moment. And I just want to say that Mike failed to say that he is a co-producer, co-creator of this work. In fact, we've been really privileged to be working very closely with Professor English on the research that I'm going to present today. So especially happy to be here in his home institution. All right, so let me just tell you a little bit about the commission and its findings. And I will structure my comments around probably the major sort of clunks of work, the major pieces of work of the commission. So first of all, why a commission on quality? That's the first thing I would like to discuss with you. So the Commission, Lancet Global Health, you've heard of it, is a journal that approached me to organize a group of people to revisit our understanding of quality in the health systems of low and middle income countries. We also wanted to, so we started by simply asking what's known about quality, how can we put everything that's known together and show a synthetic picture of what's going on in health clinics. That was one goal. Another goal was to think about measurement of quality. Somebody said to me recently that quality is really squishy. It's difficult to get your hands around what we mean by quality. Different people, probably if I went around this room and asked you to say one word that means quality to you, we'd have a lot of words in this room by the end. So how do we measure it? How do we get at the essence of it was one question that we tackled. And then the third area was to think about improvement. I came to this work as a health systems researcher. I'm a physician originally by training, but have been doing health systems research in primarily Africa for the last decade or a little longer. And I don't know much about improvement, actually. So everything I know I've learned through this commission. I think about health systems and their core functions. And the question was, what do we know about improvement? So we've had a series of launches of this report, and the launches are an opportunity to have discussions and to have conversations, and that's why I'm particularly happy to be with this academic audience today, because we've been doing launches with policy community and others, but hopefully the intellectual capital here is worthy of discussion as well. These are the commissioners. You can see who they all are and their bios on our website. There are 30 commissioners, and we explicitly chose commissioners who were a mix of folks from academia, yes, but also from health systems, working actively in the health systems of their countries, struggling with these issues on the ground. Why? Well, we think that those colleagues, the ones in policy and in implementation, managing systems, are people who see the day-to-day realities in a way that's very different from academics, who are very abstracted and removed. So we thought that that tension between policymakers and academics would actually be a constructive, productive tension to keep us academics honest and focused on what matters. So we have a really wonderful mix of ministers of health, directors of health, academics, and others. Oh, and we also work closely with the World Health Organization and the World Bank. So now, why quality? Why is it worthy a 2-year-long effort to look at this question of health system quality? And it's really these two graphs that make the point, which is that in global health over the last several decades, probably 2 or more, we've seen a huge rise in investment, right, in global health. This country, unlike my country, has actually given a lot of funds, more than 0.7% of GDP to overseas development assistance. So we've seen dramatic rises in funding for global health. And much of that funding has been to increase coverage of interventions. What do I mean by that? Let's increase the number of people who can get to clinic to get a service that we think is life-saving. So things like immunization and skilled delivery and antenatal care and so on have been the focus of a lot of the investment. You all know about the HIV investments. Again, it's getting people to care. What I want to show you today, though, is that it struck me for quite some time that some of these coverage gains, meaning people contacting the health system, are rising. Those numbers are rising, but it isn't always clear that health is rising along with that. So I want to show you a little bit of data on maternal mortality. All of the countries on the x-axis here are countries that have near universal coverage with facility delivery. So what do I mean? All babies are essentially born in hospitals, okay? Or clinics or health centers in the health system. So 80 to 90% coverage, which, by the way, is no mean feat. A number of these countries were at 40%, a lot of home deliveries, right, for many decades. All these countries have achieved 90% coverage of a life-saving intervention, which is facility delivery. That's where we can diagnose the problems and do something. And what I want to show you now, that red line is the Sustainable Development Goal target for maternal mortality, which is 70 per 100,000 live births. And so you see some countries, and they're arranged in order in groups of income. So the ones on the left are low income, low middle, and the ones on the right are high middle income countries. I want to show you, this is what's supposed to save lives, coverage of skilled delivery, because a lot of the maternal and newborn mortality is actually generated during the birth process. Okay, so several countries are at that Sustainable Development Goal target. Same coverage. Other countries are twice that target, and yet other countries that have nominally provided coverage of life-saving interventions are not saving lives. We have mortality that is very, very high in countries with excellent coverage of this service. Let's look at newborn mortality, something that Professor English works every day on. And again, SDG target, these countries all have 90% of their babies born in health facilities, okay? And yet, some countries are doing great, others are doing not bad, and others are over here. So when you see data like this, it makes you ask, what's going on? It can't be that every facility delivery is equal to another facility delivery in terms of what it's providing. We need to look under the hood. And so the equation that really started this commission is this, which is that the health system's health improving capacity rests on two ingredients, right? One is that people will come to the health system when they are sick. That's the utilization. And the second is when they contact that health system, it can do something for them. It'll provide the quality of care that can convert that visit to health. So let me just say that again. A visit to a health facility needs conversion to health. It doesn't automatically happen by walking through the door, right? Now, I hope some of you are sitting in your seats and saying, what about social determinants? Where is that? This is the health system here. But we all know that social determinants, it's education, and it's wealth, and it's empowerment, and it's water and sanitation, and many other things are critically important contributors to that H on the far right side here. And that is true. And what you need to be thinking about here is that the health system is one piece of this puzzle. It's by far not the only piece, and maybe not even the most important piece. So we do need to keep people healthy. We do that through social determinants. But when they get sick, or when they need access to health promotion and prevention, that's where the health system's job is. And it is the health system's job to improve population health. So those two pieces are not contradictory. They need to work in sync. Okay, so we went from the Millennium Development Goals, which had sort of three rough areas of work, maternal child health and infectious disease, to this situation, which is, does anybody know what I'm showing here? This is a little test. Sustainable Development Goal 3, that's right. That's the one goal on health. We went from 3 goals out of 8 to 1 out of 17 in health. But by the way, we did grow in terms of the areas of focus. So these are all of the sort of target areas in the Sustainable Development Goal on health. Now, you might notice they're highly heterogeneous. Very many health conditions are now the remit of countries to deal with. That's what 192 countries signed a declaration that says we're going to reduce mortality from these conditions. So what's the difference between the situation of 20 years ago and the situation today? I would say there are 2 big differences. Today, we have more and more complex health needs. So whereas we could deal with some a proportion of child mortality by improving water and sanitation and by giving vaccination, right? In order for us to deal with non-communicable diseases, tobacco control, substance and alcohol use, those are much more longitudinal, chronic conditions that require health systems to function over time. Also, they're much more complicated to treat. Why? Because the people that we have saved, we have a good problem right now, right? We've saved a lot of lives. Countries have saved a lot of lives of young children and mothers and others. And what that means epidemiologically is the remaining mortality is more difficult to treat. It's not the easy stuff anymore, right? It's the babies that were saved after not drinking contaminated water, but now they have something much more complex. So these 2 challenges are raising a new bar for health system function and performance. Okay, so that was the motivation for the Commission on Quality. It can't be that coverage is achieving everything by itself. We need to look at quality. And then it struck us that although this wasn't directly in our original game plan, that we needed to define health systems because all of the measurement and all of the data should really fit a definition. What's a health system for? So we spent quite some time thinking through that question and very much thinking of it with the lens of today, not the lens of 15 or 20 years ago when the last big definitions of health systems took place. All right, so this is what we came up with. I'm just going to cut right to the chase. We don't have a lot of time. This is the definition after a lot of deliberation that the Commission came up with. And that is that a high-quality health system optimizes health in any given context. And this is really important. It's going to look really different in Kenya than it does in Ethiopia, than it does here in the UK or in the US. So context really matters. But every health system everywhere must do 3 things. Consistently delivering care that improves or maintains health, being valued and trusted by all people, just a separate and complementary goal to the health goal, and responding, changing and responding. So you probably would be familiar with the consistently delivering care that improves or maintains health. That seems pretty core. I will want to emphasize the word consistently. I think all health systems deliver good care some of the time in some places for some people. That's not what we're after. We're after consistently being able to count on that, okay? That's the consistently part. The valued and trusted, I think, is absolutely critical, both as a instrumental objective, meaning that people who trust their health system come back to it, maybe stay on treatment better and so on, but also as a separate and intrinsic goal. Health systems are social institutions. If people don't trust their health system, it's like they don't trust their education system, or a challenge we have in our country, people wondering about the courts and whether those are going to be fair. So this is a key social institution in which trust is essential for it to function. And the last point is about responding. Health systems are really complicated, and once they have a pattern of working and functioning, they tend to be ruled by inertia and not really by active adaptation. And yet we know every day that needs are changing. In your country, I'm thinking about countries where we've done research in Liberia, for example, where any day there could be an outbreak or a new outbreak, and yet systems have to deal with those as well. In addition to the definition, we came up with this framework for conceptualizing high-quality health systems. And I want to just draw your attention to the top two elements on processes and impacts. So we think that, first of all, health systems are underlined by values. And those words around the framework are the values that we think health systems need to espouse, should be espousing. First of all, that health systems are for people. Let me just pause here. For people, for users, for communities, and nations. They are not for bureaucrats, they're not for economists, they're not for doctors or others. They're fundamentally for their user. Yes, we should be absolutely conscious and careful in how we maintain and support the workforce. And we should be careful not to spend too much money, and we should be careful to do financing right. But fundamentally, they're there to serve the population and serve people. And they should be equitable, resilient, and efficient. Now, the top two boxes really speak about the things that I think people value in their health system. So we've turned this framework around to make it not be a technocratic piece, but rather think of it from the perspective of the sick person who comes into healthcare. What do they want? They want a competent system to treat them, and I'll explain that in a moment. They also want competent care in the moment that they're seen by the provider. They also want to actually be respected. They want a good user experience. They don't want to wait 3 hours to have that visit. They don't want to be talked down to. So that's really an important piece of the process. And in terms of impact, of course, people want better health, including self-reported better health, not just something objectively measured on a blood test, perhaps, but also, are they feeling better? Are they able to function? Are they depressed? Are they able to go on with their daily lives? We talked already about confidence in the system. And of course, economic benefits. People want to be able to do the things that are generating income for themselves and families. And to do all of this, they need a foundations, health systems, of course, which includes population governance, platforms, and so on. Throughout this process, there should be a learning, again, to keep the system from becoming rigid and siloed. We need a learning set of processes. So that's the high-quality health system framework. I want to just make one small distinction, because I think you all understand positive user experience. It has to do with respect, with customer service. I think it's very clear. You've had some of the debates in this country. I can see a little bit of the reverberations of that as well. We've had them in the US and elsewhere. But let me distinguish between the system competence and the care competence. All of us want a provider who knows the latest stuff, right? Who knows what to do with our particular condition or the latest recommendations on this particular prevention measure. That's what I mean by care, competence care. Within the care episode, you want someone who knows what they're doing. But in addition to that, you want the system to be competent. You want the person to be able to refer you and you to get that referral. You want the system to, if you have a breast lump, to be able to deal with that very quickly, within a week or less, not months. As some of the data I will show you in a moment. So timeliness, safety, prevention, detection, those are things we expect systems to do versus individual providers. And then quality impacts I've already spoken about, and we'll come to some of these in a moment. All right, so that's the definition. I want to turn to what do we know about quality today. I want to start with this top line number. When the commission was published, we also published this as a separate analysis in the Lancet that same day, in which we did an analysis of amenable mortality, something that actually colleagues here in the UK pioneered to compare European health systems. system. And we specifically chose conditions that were treatable in most low and middle income, but SDG conditions that countries said, okay, we can deal with this. And what we did is we compared case fatality rates, mortality for those conditions for age and sex standardized groups, between LMICs, low and middle income countries, and 30 best performing high income countries. What does that give us? It gives us the range of possibility. How many people could we save if we were all performing up here? So from those excess deaths that we identified, we split them into preventable and amenable. By preventable, we mean that although 15.6 million, if you add up the two chunks, 15.6 million people are dying in excess of what they would be in a good quality system, it isn't exactly fair to task the health system with saving all of their lives, right? Because some of them shouldn't have gotten sick in the first place. They should have been, their cases of disease should have been averted through public health prevention at a population level. Does that make sense? So we subtracted the extra incident cases. I'm happy to get into that methodology more because it's so much fun. But that's what I mean by preventable. Those deaths, we're not even giving them to the health system. We're saying should have been prevented. The smoking laws and safe roads and so on. That's what's over here in that teal color. And then amenable is what we're focused on. So in addition to those deaths, there are those cases that would have gotten sick in any country, but should have been saved by healthcare. That's the 8.6 million. Here's what we further found. We looked at surveys from low and middle income countries about how often people use healthcare for those conditions, for those excess deaths. And we applied those utilization figures to that number and found that 5 of the 8 million deaths are among people who are in contact with the health system. So we're calling those poor quality deaths. And 3.6 million are among people who don't use the health system. Now, this is a very broad first sort of take on this. And I can tell you right now, utilization data do not exist for every condition. We had to make some simplifying assumptions. And so you should see this very much as indicative, but it's giving us a sense of the weight of poor quality and the burden that poor quality is exerting, already killing 5 million people who are coming to the health system and dying. And we then were able to apportion this across different conditions, and you can see that quality, which is the blue bars, or blue segments, is a big deal across many conditions in low and middle income countries today. Cardiovascular disease, neonatal health, so many newborn deaths are happening, just like I showed you in that slide, in babies that are born in facilities where they should be having these conditions detected. Road injury deaths, and so on. Can anybody think of why the cancer deaths seem to be not so associated with poor quality, but rather more due to poor utilization? Cancer deaths in low and middle income countries. Any guesses about why that is? Yeah. Yeah. Exactly. So I don't know if you heard your colleague, but most people present very late in the course of disease. So in fairness, we couldn't say the system failed. We don't know yet because a person came so late that it was. So there's a utilization problem still in many conditions. But I think we have to say to ourselves, well, if they did use the health system, would they get better? Which is a separate question, right? Okay, so that's why we have some of those red or orange segments there. Okay, so of course, good quality is about saving lives and also improving people's quality of life, but it's also about economic benefits. And there are at least 3 categories of economic benefits that accrue from high quality health systems. And they are obviously reducing premature mortality means people can work longer. And when they work longer, you see this level of economic welfare gain, in this case loss, because they've died prematurely. So this is another analysis that was done for the commission. But in addition to that, unnecessary and harmful care is costing money. There is waste in systems. And as well, people themselves are paying out of pocket and going broke, paying for healthcare that may or may not be effective. Okay, so I just want to turn, so if you think about the framework again for a moment, we were talking right now about health impacts, right, and economic impacts of good or poor, in this case, quality health systems. Let's turn to the care competence. What does the provider know? What does the provider do when a patient comes to them? So these data that I'm showing you here, each dot is a country. And these are data from a very large body of new analyses that our team conducted with facility surveys. These are nationally representative surveys of health system facilities. And one of the nuggets of wonderful information they contain is care observations, by which I mean somebody stands in the corner and observes care over time. What are you thinking when that happens? What could be the problem with that sort of a instrument for, yeah? Exactly. Right, so let's see how well they did when they're watched. Okay, so what I'm showing you is the proportion of items that providers did in family planning, sick child care, antenatal care, and a couple of data points from delivery care when they are observed. Somebody's in the room watching them, not hidden. And on average, they're performing half or less of the recommended basic clinical actions. That's their best, okay? Half the content of care that is expected to do a proper differential diagnosis, to be able to figure out what treatment regimen to give, to counsel the parent, to let them know what to do with that sick child, that's not happening. Okay, so we're getting half the recommended items. You can see antenatal care doing a little bit better, right, than sick child care. And these are from about 18 countries, I think, where we have these incredibly precise data, typically low-income countries. Okay. I want to also then turn, so part of competent care is getting the right treatment. So here is data on right treatment, effective treatments. So in pregnancy, tetanus injections are incredibly important to protect the newborn from dying from tetanus. Obviously, oral rehydration therapy, antibiotics. Just look at the performance. These are simple things the system should be doing consistently without fail, things we've known about for several decades. And you can see the spread of performance on just very, very basic therapeutic actions. I just want to draw your attention to an area in which we know almost nothing, which is this, depression. There's just one large research study, a set of surveys on mental health and people with major depression. And this is the proportion of people who reach the health system who get minimally adequate treatment for their depression, meaning at least 4 visits with somebody who knows anything about counseling or some psychotherapeutic medication. So it's just basically, there's nothing going on mental health at all in the health systems of these few countries. We also don't have very much data, as you can see. Okay, so that was just a little glimpse of the care competence. I want to shift us a little bit to user experience. What do people experience when they go to healthcare? And again, we pulled all available surveys. I had my team count how many surveys we reanalyzed. We got the raw data and we reanalyzed. It was 200 separate data sets. We have an amazing team, very fortunate, that was able to do that. And here we're looking at all sorts of surveys. We basically combed the global literature, and these are Afrobarometer surveys, DHS surveys, IADB surveys. We did our own survey because we couldn't find data that we wanted, so we actually did an internet survey in countries with at least some internet penetration. Obviously, you can't do this everywhere. But just a few points. Just look at overalls at the sort of scores. About 60-70% of people are saying, okay, the treatment wasn't so bad. GP spends enough time with us, was about 60%. Let's see, we asked about sort of listening, or other surveys, asked about listening. You would get about 70% of people saying, on average, yeah, the person was listening well. Explains things in a way that's easy to understand. I just want to point out two of these data points, or items, I should say. The GP explaining, this is low and middle income countries, and the red dots are high income countries. So one thing that's important to note is that we have challenges in this everywhere, but it is not true to say that everybody's got the same problem. It's not the same. Let me be clear, it's not the same. The reality right now in global health is that the bulk of the burden of poor quality is falling on the people who can least shoulder it, which is the people in low and middle income countries. It's not the same. The problems you have with your GP, or I have with my GP, not the same problems, okay? So here is the item around understanding, explaining things, enough time. Here's the high income countries that are getting much more time with their clinician. Let me probably pause on this. There's a lot of data there and more in the report that I welcome for you to look at. But it's not just numbers, right? It's quotes like this. We, as part of the commission, had a group called the People's Voice Advisory Board, which was a group of patient advocacy and civil society organizations that were helping us collect voices of people and experiences and stories including quotes like these quotes, that show the kind of basic disregard that sometimes health workers have, or the way that systems are set up in a way that make people feel like they're in a prison when they come to a health institution. And so I think that is just such an important, that experience is such an important part of the quality conversation. I want to dig in, I've been showing a lot of little dots. I want to dig into just a couple of findings, because you're researchers and scholars, and I want to show you some examples of kind of more detailed observations around care. So this is from a paper that some of the commission members published, including myself and colleagues. And this was about looking in detail at the content of care for sick child consultations. So these are children who come in with an illness of some sort. 15,000 observations we had, nine countries. The maximum number of items that was even on the checklist was 24. Okay? That's how many items a physician could do. And for those of you who are not clinicians, you know what I'm talking about. It's sort of, did they ask the child, did they get the child's weight? Did they get the child's history? Did they get the child, whether the child's eating or drinking? These are basic sort of assessment. Did they examine the child? Did they listen to the chest? Did they look in the ears? Those kinds of, and then did they counsel the parent? That's what those little stethoscopes are. Those are all clinical items. So on average, the number of items performed by the clinician out of the 24 was 8.4. Okay. We had a great conversation this morning with some of the DPhil students and then later the master's students, and someone made this great point. Well, I just want to focus here that these are not kids like the kids maybe that some of us have, and we might be really concerned about that child having a cough. These are kids in high mortality countries where parents often have to travel quite a distance to get to that healthcare clinic. I would say on average, probably these kids are sicker than my kid would be when I take them to I'm pretty, yeah. I might have a higher bar for illness than some parents that I think we would typically see in a high income country. That's my only point. 8.4 items they get out of the recommended 24. The average visit was 8 minutes. And by the way, this is longer in these observations than what has been shown in a systematic review of primary care, which shows average consultations in primary care across 30 or 40 countries were 6 minutes, 5 to 6 minutes. 5 to 6 minutes, okay. So what we then said was, well, maybe you don't need all those 24 items. I used to practice medicine. Sometimes you could kind of, maybe you can get away with a shortcut. So maybe what it is that these clinicians are doing more for the sicker kids, the ones that need it. So we identified here what was done for the less sick kids and the more sick kids. And the less sick kids are these guys. So kids with any kind of presentation, fever, cough, diarrhea, etc. And the more sick kids in this slide that I'm about to show you are kids who have not kept any food down for the last 24 hours, okay, or were convulsing. So these are kids who are very, very sick by any standard. And this is how many more clinical actions those kids got. So they didn't get a thorough workup. They got barely anything more in terms of that care. So happy to speak more about this paper and its methodology, but this really, to me, raises huge red flags about what's being detected in care. And then we looked at the effects of this kind of care on parent knowledge. That's the first regression there, and parent satisfaction with care. And we see some pretty important effects in terms of the length of the visit, increasing parent knowledge, the number of items people knew what to do with their kids if the kid got sicker, and also separate effects for the content of care. The number of items was separate even from the visit length. So it's not just about sitting around, it's doing something with that time. Okay, so that is the challenge overall. Now, I want to show you that the inverse care law, again, something that came from this country, the notion that the poor often get exposed to the worst types of care, and I think that was originally said in the 1970s about Wales, was true when it comes to quality. So here we looked, each of these lines now is not a country. These are wealth groups. And what you see here is the poorest are the dark, I think these are blue, and the richest are the orange dots. And look across these services and look at how the equity looks within the same countries for kids and adults with different conditions. And really the simple message here is for most of these services, the poor are getting the worst care. That's what we see. And I don't have time, but in the report, we also talk about age, looking at adolescents, the kind of care that adolescents get. Again, we have only a very few data points, but we also see similar trends for younger adolescents coming into care, for example, compared to adults. So let's turn to competence systems. If you remember, we draw this distinction between care, the single episode, and the system overall. And one of those system elements is safety. So very major observations recently in the global health literature around surgical safety, and finding that there are many more perioperative deaths in low and middle income countries, also surgical site infections. Systems, although we've known about pap smears for I don't know how long, very long time, systems are not getting these women into care, not picking these potential cancers up. That across countries, this is now a completely shared problem in rich and poor countries, this one. 1 in 5 people in ART stop treatment within 1 year. So this is completely essential. This is a life-saving treatment. People need to stay on treatment. Again, I hope you're questioning my assumptions here and saying, well, how is this a systems problem? Shouldn't the person be responsible for adhering to care? It's actually a really important question to ask. The way that we conceptualize this in the Commission is this is a co-produced outcome. The system's got to do its job, and of course the person's got to do its job. But if the system doesn't inspire trust, right? If you think about other service sectors, the customer loyalty and trust and coming back are key measures of that service or of that product, right? So should they be for the health system. Timely action. This is one of the most frightening figures. This is data from 4 countries that the average time from a broken thigh bone, femur, to operation was almost 12 days. 12 days that person's lying in a bed, not able to move, versus what is a more reasonable standard of half a day to operation. And also huge, huge delays. You mentioned already people are coming very late with their breast lump, something they're concerned about. Yes, they're coming late, but the system is also incredibly slow from that point on to make a diagnosis, and when it makes the diagnosis, to progress to treatment. So timely care, I just really want to emphasize, if you're sort of paying attention, put a little asterisk. We've been really shocked by how poor timeliness is and how important that is to survival. Population health management is another aspect of competence systems, and this is about knowing what your population needs. Like, how many people in this community have high blood pressure? You know, the health system should know that. And what we see is, again, poor management of those sorts of public health prevention activities. In just a few weeks, there will be a big meeting in Kazakhstan to celebrate or commemorate. I'm not sure how much celebration there is, as you'll see in a moment, as you're seeing now, for primary care, the Alma-Ata at 40 conference. We tried to assemble all the data that we could from these nationally representative surveys in low-income countries, trying to construct these competence system measures, evidence-based care, and user experience, using all the items in these surveys that were available. So not perfect, and would love to repeat this when there are more data. But at least indicatively, you're seeing performance on this 40% level, basically for primary care. And then what you can do is look at it for different elements of competence systems, like prevention or evidence-based care or user experience. So again, this paper is actually about to be published probably tomorrow. And then what you can also do is look subnationally to say, what's going on within my country? Because frankly, Ethiopia may not be that interested in what Kenya is doing, but it is interested how that care looks across its country. And I think that's really important. These data should not be for global consumption only, far from. They should be for domestic consumption. And that's why in the Commission, we had so many national policymakers as well, who are, by the way, acting in this and upset by these data, which we're delighted to see. That's the first step. There's more costs to this kind of care that I'm describing, which is this loss of trust, right? Systems that can't provide consistently good care, can't be respectful and people-oriented, lose people. They lose patients. So let's look at India, which is now facing one of the hugest sort of epidemics of non-communicable diseases, particularly cardiovascular disease, diabetes, and other conditions, for which you would think that they have actually pretty well-dispersed primary health system. Lots of clinics exist near a lot of people. It's a huge, obviously, country, but still the penetration of the system has been good. What I'm showing you here is data from national surveys of hundreds of thousands of households that ask people, do you go to your nearest clinic as the usual source of care, your nearest public health facility? 80% of people said, no, I wouldn't go there. 80%. Now, of the 80%, what we did here is we counted up how many people quoted quality as a reason, okay? And the darker the pink, do you like our pink connection? The higher the proportion of people who cited quality as a problem. So systems are losing people. They're not coming back. They're not going there for important preventive care. And so the result of all these data is that overall in surveys, fewer than 1 in 4 people believe that their health system works well and doesn't really need major changes. That's not a really high endorsement, okay? So I've just given you a lot of data to chew on about the state of quality. Let's shift gears and talk about how do you measure quality, because that's another problematic area. And actually, Professor English was on this working group, so can give you even more detail about the notion of measurement, because it's not so clear how to approach this. So first thing that we started with, as with everything in the commission, is we asked, what is it for? Just like we said, what is the health system for? We asked, what is measurement for? Measurement really, in our view, is for 2 things, and it's got to defend itself. Every measure has got to defend itself on one of these 2 grounds, or be not collected. So the first is accountability. There's no question that health systems have to account to populations for their function, and so you need some data to be able to present to your population and also to managers within the system. The second is using data to diagnose problems, to see where there are, do you remember those subnational charts that I showed you, or maps? Do you say, well, this state is doing better than this state? What's that about? How can we guide action? What can we learn? So action and accountability are the 2 reasons to measure. And here's what we've been measuring in the global health. This is another big chunk of analysis that the commission undertook, which is really reviewing a whole bunch of global measurement sets and indicator bundles. And you can see, for example, countdown to 2030 indicators, Euro Health for All, OECD healthcare indicators, Sustainable Development Goal indicators, WHO Core 100, and so on and so forth. Below that, you can see the kinds of surveys that are being done in the health system, and what are they measuring? DHS, SPA, SARA, SDI. And then national health management information systems, HMIS systems. And the columns are the parts of our framework. So the farther you get to the right, the closer you get to outcomes, including patient-reported outcomes. And on the left are the foundations, which is things like doctors per capita, hospital beds per capita, availability of whatever, oxytocin. So you can see that we really love measuring inputs, actually, in global health. We love it. We do it all the time. Every 5 years, a gigantic facility survey comes around low-income country and counts up stuff in the cupboard. To which I say, how long is that stuff going to be relevant? How long are those data points going to be relevant? So inputs are really favored in the current management, in measurement domain. And so we decided to look a little bit more at measurement, measurement of inputs. And what you see on the x-axis in this paper is what's called service readiness by the WHO. What do they mean? They mean how many items, clinical items, are in that clinic. Is it ready to function? And for a very long time, this notion of service readiness was used to approximate quality. It's basically saying if you have 100% of the items, right, you are going to do a great job, or at least you're going to do an adequate job. And what we do on the y-axis, what we did on the y-axis here is we included those observation measures that I've been showing you, what people actually do when they're observed. So look at the correlations between the readiness and the performance of the providers. It's not impressive. Furthermore, even in countries like Namibia, for example, where you can say, okay, there is a little bit of a correlation, it's 0.33. Just look at the spread. Look at the spread of observations around even well-stocked clinics and how much poor performance there is in those clinics. So just because I can put a line through a cloud like this does not show, and I think the size, also the slope of this line, I hope is relatively persuasive to you that inputs do not create good quality by themselves. Are they needed? Yes, absolutely. You need all these things. We should all aspire, every clinic should be on the right side of this line. But the point we're making here is it's not a proxy measure for quality. It's just not. Okay, so not only are we confusing measures of inputs for measures of quality, we have other problems in the measurement sphere. One is that we're not measuring things that are causing a lot of pain and disability and mortality. So some of the things that we knew about for the commission are in the dark colors here, and the lighter ones are things we knew almost nothing about, where we had to dig, and we had multiple conversations with experts in these areas to say, show us the data set, where are the data on quality for this condition? And they couldn't point to one, or they couldn't point to something that was national in scope. They were small studies in a few clinics. So we just don't know anything about mental health or cancer, very little. Neglected tropical diseases, the quality of care for those things, the quality of care for injuries. I already mentioned mental health earlier. And so how do you improve measurement? Well, there's at least 3 principles we would like to suggest. One is to stop measuring coverage, and from my very first slide, coverage by itself obviously does not create quality. Now, why am I belaboring this point? I've already said it a couple of times. Anybody follow the universal health coverage discussions that are going on at WHO? Anybody know what some of the, I see some hands up, which is great. What are they measuring? How are they counting success on universal health coverage? Anybody remember what's in that index? I probably gave it away here, but it's covered. Oh, yes. Right. Right. That's great. Exactly. They have 2 components. One is on catastrophic health expenditures. We don't want people, again, paying too much out of pocket. But the other piece is on health. And by health, they have 2 types of indicators. One is simply health outcomes, how many people are dying. I would say some of those indicators are not always health system related, right? Some of them are related to social determinants. That's one problem. But I like those because mortality matters to everybody, so we should be tracking that. But the other part of the health measure is service coverage. It's saying what % of the population has access to service X. And as we've been saying, it's just not enough. So the reason we need to move from coverage to effective coverage is that coverage alone is not a proxy for functioning universal health coverage or for a functioning health system. It's got to be effective coverage, by which I mean quality corrected coverage. Second point that we want to stress is adopting fewer measures, but better measures. We'd like to wipe out large parts of facility surveys, just get rid of them entirely, and think about new data points, new ways of collecting information. So revising both the what's measured and counted, but also how. And then the third, and this is so critical, we have to invest in a serious way, not like 1 week's data trainings or something, but in a serious way over time in training the scientists who are going to do this kind of work in their own country. And I know that you here at Oxford are involved in that effort. Many of you, I am so happy to see, are from countries that you're going to go back to and use this knowledge. And same with us at Harvard, of course, and many other institutions, and wonderful institutions in the countries, in LMICs themselves. But this is such a critical piece. We just don't have enough health system scientists right now working on these issues. So coming to the what and how, what should we measure? We think that the emphasis needs to move from inputs to very specific areas. And the 4 that we like especially are health. We should be concerned about that since health systems have to produce that. And we should be, these are just some examples. These are not a comprehensive list. It's more to just give you a feel for what we're talking about. These measures are health system sensitive outcomes, meaning really relying on health systems to help achieve those. Competent care and systems, people's confidence in healthcare, including retention and trust and recommendation and so on, and patient experience. And how do we do this differently and better? Well, I think there actually is a bunch of innovation that could help us do this. How do we assess care competence? Well, maybe we could have interactive vignettes that are adaptive to the provider that can help us understand where their gaps are. I'll skip some of these because they're very exciting, but they would take too long to explain. I want to just talk about happy or not. When I got out of Heathrow this morning, I saw the ubiquitous happy face, the 4. I was thinking, Mike, about how many categories there were 4. I was like, that's good. We'll do that in clinics. But it's essentially, the smiley, frowny face emojis that you get. There's been really interesting research done on those. And they actually change the way that services are managed and have a lot of influence in helping people understand where gaps are. Why not put one of those in every clinic? Every clinic in Kenya, every clinic in Ethiopia. We'd have time-coded, extremely low-pain data that health workers don't have to do anything about. Patients do on their way out. Right? Now, it wouldn't tell us everything, but it would be a really interesting data set, right? It would tell us something, and it might be very helpful to managers. E-cohorts. So system competence means that we have to evaluate people over time in health systems and not just at a moment in time through one observation. So can we get people enrolled in e-cohorts where we can watch them go through, through their mobile phone, which, by the way, everybody has in every country. I was reflecting on a time we were visiting our project sites in Tanzania for a cluster randomized trial there. And I was walking along and chatting, and I was going, why is a woman in front of me going so slowly? This is like a dirt road in rural Tanzania. It's because she was on her phone, of course, and had to go around her. And I tweeted the picture. I was just like, this is it. We're there. We couldn't do anything. But, you know, mHealth is not going to solve this for us. But it can be a tool. It can be a help. Okay. And so how do you bring it all together? Well, one idea is something that we want to borrow from HIV and AIDS, which is the notion of a care cascade, because people need multiple touch points to be well, right, in the system. Many people, not every condition, by the way, of course, but many, especially the complicated ones. So you could be measuring what your health system is doing for people along the course of their illness. And that's one way to summarize it for policymakers. And I find policymakers really respond well to these care cascades because they're very intuitive to follow. And then ideally, you bring all these data together and you share it with the populations through a dashboard that they can get on their machine or on paper or in community meetings about measures that they can relate to, things that matter to them around competence, for example, safety, timeliness. And then you can do the sub-national disaggregation as well, because it's even a deeper level that's required than this, but this is a start. Okay, I want to move to rethinking improvement. So if you're feeling like we're provoking a lot of, the commission has the word revolution in the title, not for no reason. I mean, we really wanted to take a fresh look at a number of sort of the traditional approaches to thinking about health systems, but also that same spirit of inquiry and openness to any direction the data took us was apparent here in our work on improvement. So we looked at all of the improvement science that we could get our hands on, including having commissioners with a lot of expertise in this area. So this is improvement, work on quality improvement, QI, and so on, that's out there, and that is applied to countries in low and middle income parts of the world. One thing that we observed, and this is from a review that WHO did in conjunction with us, was to say, where are improvement efforts located? What are they focusing on? And what we found, and this is really sort of this level of analysis, is it the micro level that they're focused on, the meso level, or the macro kind of system level? And what you can see from this is that about 3/4 of improvement efforts are really at the micro level, at that interaction between user and patient. Sorry, user and provider, or clinic and patient. Can anybody think of what do I mean by these micro level interventions? What's an intervention that's trying to change provider behavior? Any ideas? You have them here. We have them also. They're everywhere. Yeah. Very good. In-service training, right? The famous 1-week course or the 2-week course. Absolutely. That's one of the most commonly used what we call point of care interventions for improvement. You just tell providers what to do. Give them some training, show them some videos. Okay? Great. What other ones? Anybody? What else is really in vogue in many low-income countries? Or other ideas you have? Yeah, apps and devices, exactly. The things that are supposed to, they're called job aids or decision support or whatever, those things are also being increasingly used. And so is supervision and PDSA cycles and sort of Lean and Six Sigma and all of these kinds of interventions, which are there for expressly one reason: change what the provider did yesterday into something better. So that provider is going to perform better once they have this. And so we think of these as local solutions. They're facility level, focusing on behavior change. They're very local scale. They're often a clinic at a time. They're quite intensive. And what we're saying is, wait a minute, is this where we should be putting all our eggs in this basket? Or should we be thinking about the harder stuff, which are structural, macro improvements, which are system level, will take longer to implement, but have the potential to be effective at scale. So let me just give you a little anecdote, results of a very important study that taught us a lot about local improvement. How many of you have heard about the Better Birth Trial? You don't count, Mike. Okay. He might know about that. All right. So the Better Birth study is one of the most interesting recent examples of implementation science, very rigorously done study to evaluate a particular intervention. And this is the picture of the intervention. 160,000 women were involved in this study. Why so many? Because it takes a really large population like that, a large sample, to document a reduction in maternal and newborn deaths. Okay, so incredibly ambitious, very large study in India, which involved, I think, about 160 different clinics, and which tried to do this thing in the middle here: coaching, data feedback, and measurement of performance to let the skilled birth attendants know, nurses, midwives, clinical officers, know what they could be doing better. Like, what did they do? What could they be doing better? Coaching them. Very hands-on, very high-touch interaction. And all of this was done in clinics, one clinic at a time, provider at a time. And the goal was these providers would figure out what they were missing, right, from these guidelines. They also had apps and guidelines and checklists, and they would do it better the next time. And sometimes they would have a coach standing there over them and suggesting that. The idea being that they would improve maternal newborn mortality. Anybody know the results of this trial? How much did this accomplish? So first of all, there were two outcomes. One was a process outcome, which was adherence to good practice in delivery, okay, delivery care. That did wonderfully well, okay? I think it went up, what was it, 30 points initially, fell down after a year of this trial to maybe 18. Like, there was some attrition of those new skills, but there seemed to be more skills that were being practiced in deliveries, during deliveries. And what about maternal and newborn mortality? What do you think? 5%? It's a high mortality country, by the way. This is not the situation where you're starting from a low base and hoping to improve. Null results. Zero improvement in survival. And this isn't just maternal mortality, which is hard and few and so on. This is a composite measure of mortality and morbidity. And all of the reanalyses that were done and sub-analyses and different analyses showed the same null result. A very solid null is what we call this. Now, there are many hypotheses about why. It's not because the study was not implemented well. The team that did this is actually a top-notch team. They had great collaboration in India. It just didn't matter. It just didn't make a difference, okay? And so the point that we take from this in the commission is all of the improvement was focused on provider behavior change, and the broader system was unperturbed. Yes, they provided some equipment and so on, but you just saw equipment doesn't create good care, right? But what's noticeable about this study, notable, is that at the beginning and at the end, the C-section rate in the study was 1%. 1%. Now, the latest data suggests that C-section rates around the region of 20% are optimal for maternal newborn mortality reduction. And C-section is not the only thing. My main point is it's a proxy for what the system couldn't do for women. They did not change the system. They tried to change the providers. Okay, so from all of these kinds of observations, the commission came up with what we call 4 universal actions, which are the 4 structural changes that we think every country needs to at least engage with. They're not going to look the same in every place, but they're the 4 big deal, high potential areas for improvement. The first is governing for quality. What I mean by this is that very often quality has been relegated to a directorate or a side unit in a Ministry of Health. I think that quality should be the main job of the Minister of Health, and maybe even the Minister of Finance. What is the health system for, if not for good quality? So why should it be somebody else's job rather than the minister's job? Quality is the DNA of health systems. So the idea that it's sidelined or it's an advisory group to the main work of the Ministry of Health makes no sense. It is the Ministry of Health's work. Further, there needs to be alignment on quality right through the system, from the Ministry of Health on down, with real consequences when people don't do a good job, when clinics don't perform. My colleague in Tanzania used to say, why do I have a different quality strategy for TB and another one for HIV and another one for maternal child health? I don't even understand what binds these ideas. We need a coherent vision and a learning system, a way to spot errors and also to try solutions. So governing for quality is critical. The second is redesigning service delivery to maximize outcomes. So let me just pause on this one because this has been quite, this has provoked a number of communities into thinking a little differently and perhaps not something that's as familiar as others. So we start with the proposition that health systems in many low-income countries started out by trying to expand services to as broad a number of people as possible. And that's a great thing when those services are basic and simple. But in that push to expand coverage and promote proximity, we've sort of diluted quality. So at the first level, in many, many countries, you have very rudimentary clinics, which can only do so much. And yet, they can do some things extremely well, right? Promotion, prevention. I'm thinking here of Ethiopia's health extension workers and many of the wonderful and dedicated, folks, nurses and community health workers and others doing promotion and education work and so on in first-level clinics. That's great. But is it fair to also ask them to deal with a postpartum hemorrhage? Is it reasonable to say they should save a gasping newborn? No, it is not, we say. So I think what we're saying here is redesign the system. You've got assets in the system. They're health workers, they're facilities. Think about how to reorganize service delivery so that you're promoting outcomes and quality and not just promoting access. So that may mean that, for example, deliveries that can at any moment turn quite dramatic and complicated should not be happening at primary care clinics. Let me show you the results of one of our studies. This is annual delivery volume on the x-axis. On the y-axis is a very basic measure of maternal health quality, including the ability to deal with complications. And these are data from 5 countries, in which initially the study question was, is volume associated with quality? A question that is asked a lot in high-income countries as well. But we found something else that was more interesting. Yes, volume is somewhat associated, probably. But what was particularly striking to us is that actually the red dots, which are hospitals with surgical delivery, were much better performing on those basic measures of quality. And yet, in these countries in the study, 1 in 3 babies born in a facility was born in one of those primary care facilities, those blue dots. And so is that the norm? Well, actually, no. This is the global norm, which is that almost no babies in high-income countries are born in facilities without surgical capacity or with low volumes. So again, highest mortality countries are getting the worst care models, is what we're seeing. I'm going to skip this just to say that there's work that we're doing and others to say, is this feasible to move deliveries to hospitals? And for many countries, the answer is yes, with a lot of effort. Of course, that's intersectoral. It's not an overnight solution. You need to make sure those hospitals do a good job. It's not just moving mortality from one place to another, right? But also working on roads, transport, and so on. I'm going to skip this. The third sort of big idea of the Commission is that the performance we're seeing from health workers suggests that in addition to the previous 2 things, we really need to fundamentally reform training, clinical training, medical, nursing, midwifery education. There are so many people in that Better Birth study, so many of those health workers commented that they'd never actually seen a postpartum hemorrhage at any point, not once in their training. And yet they're totally responsible for saving a life. And I have dealt with postpartum hemorrhage, and I know that many of you clinicians in this room have probably seen and can share how terrifying and how difficult it is to stop that flow of blood. It's not straightforward. And yet every day we're asking people who have never seen one to deal with it and be responsible for that survival, for that mom. So it's strengthening health professional education, much more competency-based education as opposed to memorization of pathology and slides. And also then when those professionals come out, making sure the work environment supports excellence and demands excellence, and both rewards it but punishes it when it's not there. And then the last area really is igniting demand for quality. So just a word about this. People do care a lot about quality. That is very clear from surveys. It's very clear from people's behavior in the health system. But we also know that people don't always understand it very well because it's very technical. And maybe they are distracted by the injections and the beautiful waiting room and so on and think that's quality. But it's not always true. So for example, when we did our internet survey, we showed this quality description or this care description, which is actually pretty poor care for a hypertensive patient. The nurse doesn't take the blood pressure. She doesn't do a number of things that should be done. And we noted that across these countries, more than half the population thought this looked like good care to them. And so there is a problem in understanding what is good quality. And part of the solution here is to engage the population much more in this understanding and educate them, but also empower them. Because populations that may be educated but don't get any response from the health system also don't do much good. So this is a two-way street. So I think I'm going to skip sort of the recommendations. You can read them in our report. For this audience and for our conversation, I wanted to share some of the key findings and provocations from the Commission. Provocation to think differently and to really think about launching a revolution on quality, because business as usual is not going to cut it. So let me pause here and take any questions if we have time.
Great. Margaret, thank you so much. That was a really wonderful discussion of a whole range of issues that I think are things that resonate not just with people who work in public health, but also in improving education and improving civil services across a whole range of public services. So we're going to take questions now. We'll take them in groups of 3, and please keep your questions actually a question and to 1 question each, please. Yep. And we'll have microphones going around.
Name's Simon. Ken, a quickie. Is this all public sector, public and private? Which? And did you look at the difference between the two if you do have data on both?
Thank you very much for that, and congratulations to you and to the rest of the Commission for some really inspiring work. As a bit of a data nerd as well, the amount of work it must have taken to assemble the data that you've described is quite incredible, so congratulations. My apologies, Martin, that bit was not a question. So much of this echoes what would also be said about the most developed countries in the world. How far is this, 2 questions, how far is this specific actually to low and middle income countries? And 2, if the richest countries in the world are still struggling with this, what's your grounds for optimism that we can shift quality in the poorer countries in the world?
Sure, yes, good, thank you, because my attention span after the flight is probably not as great. So to answer your question, it is a public and private sector that were included, data from both were included in these slides. The nice thing about these facility surveys is they actually sample from both. So we do have data on both sides. Now, that isn't to say that we know as much about the private sector in general, because those facility surveys are for a specific group of countries, and a lot of the other data I was citing do come from public health systems. Your other question was which one does better, and that is, I can tell you the answer. At least in the 18 countries, which are primarily in sub-Saharan Africa, but also some low-income countries, Nepal and others, Haiti, we do see a slight advantage for private sector, accounting after controlling for equipment and so on, because you can always say it's just a matter of resources, but we try to control for some of that and see that there's a couple of point advantage in terms of provider performance for a number of these, but it's not large. If the average is 40, we're maybe seeing 42, in the private. But that is by no means the final answer to your question. There's a lot that's not known. In India, 80% of service provision is private. We have hardly any idea about what they're doing. And your question. We've been asked this question a lot, and a lot of our work is motivated by work, of course, on quality in high-income country health systems as well. So we've always had this walk back and forth, and we've worked with OECD and the World Bank, who work also with these high-income countries. So we've tried to borrow the best ideas, including a measurement and things that have already not worked in high-income countries, hoping that maybe the low ones could skip it. So that's always been there. We've always been very interested in what's being learned. I would say that in terms of applicability, and I always want to be, I'm a researcher, so we always have to say these data, these results only apply to the countries under study, and that's true. We don't say anything here about the UK or France or the US. The way that I think about this is, I think the principles that we are looking at apply across. I think that the definition of health systems, to my mind, that would be a great health system if we had that in the US, if we could met those 3 criteria. So I think the principles broadly apply, the values and the framework apply. I think, though, that it's very important to distinguish between performance in high-income and low-income systems. I think one thing I'm seeing, and we were talking about this a little bit earlier, is that there's some slippage of ideas in the sort of desire to have solidarity across countries. I think we're saying we all have problems. And that is true. Health systems are always a work in progress, for sure, and not solved, right, and not static. But I think on these issues of quality, of care competence, of system competence, it really is night and day right now between what we're seeing in the poorest, most vulnerable countries and peoples compared to what we have here. So we have our own problems to solve, but they're not of the same magnitude, if that makes sense. Yeah, those two.
We do 1, 2, 3. Oh, since you have the microphone, go ahead. The other one's back.
And if you can introduce yourself, fine. Ah, I don't think so. Yeah.
Not end of life care, but it just
Yep.
is extending from the moment of diagnosis, whether it's non-communicable diseases or through. So our experience is that where we taught it not in PowerPoints and things, but actually in a meaningful way. It's had huge impact in improving quality of care no end.
Great.
Hi, I'm Jake McKnight. I work with Mike English, wherever he's gone, in Kenya. I'm particularly interested in infection prevention and control and healthcare-associated infections. The whole first do no harm thing always made me think that we could be doing better there, and there's so few data for IPC, as I'm aware, and especially for HAIs. I was wondering if that's an area that you mean to pick up.
I think you have captured the true spirit of practicing in low and middle income countries through this research. But my question is that looking at the data you've presented, especially about the 8 minutes consultations, the same healthcare worker would probably be working 80 hours a week. So have you factored, was there a factor in for task shifting workers where primary healthcare services are not delivered by medical doctors? And also, did you factor in the patient-doctor ratio in terms of the quality of care?
Great.
So palliative care.
Thank you. Let me come back to you. Okay, palliative care. Thank you for asking that question. I think that Felicia Null recently led a commission on palliative care, and I've been very influenced by that, and I also, just even from my medical practice and from the understanding of what the health system's job is, right? It's to relieve suffering. Yes, we keep people alive, but they need to have a place they can go to deal with their pain and their anxiety when their illness is incurable. And so we do talk about, and I think you're saying it's not just about incurable, and it's not just about end of life, but it is about quality of life. And I wish we had more data is probably my short answer to you. It's one of the slides I show talks about suffering, and can we incorporate measures of suffering as a health system performance measure? And I think that would be one way forward. I think sometimes measurement can help normalize and shed light on this. And I think your approach of fewer PowerPoints and more conversations, ideally not just with health workers, but again, going up the chain, the structural chain with ministries, that this matters hugely, and it's incredibly essential for health system function. I completely agree with. So I think we didn't pay as much attention as we could have or should have, and partly that was a real limitation of data. We just know so very little in these settings. IPC and avoiding health-associated infections, absolutely. This is why we were very interested in data from surgery, for example, or some of the hospital data from your group around, the harms that come with poor health care. It's exactly right. And we think of safety in our framework and in our approach as a system competence measure. A competent system does not allow its users to get sick. When you walk into a store and you keep tripping over the curb, something's done about it. It's just a basic feature of customer service, and certainly in healthcare, it's especially ironic, right, that we would let people get sick coming into care. So we do talk about it, we do mention it. I think one of the challenges in a commission like this is just the scope is so large that when people ask me, sort of, did you talk about X? I said, well, we did, and it's in 3 places on 4 pages, but obviously there's much more that could be said, and there is great work being done, actually, in IPC, especially post all the outbreaks, but definitely not a solution. One more comment on IPC is that it's one of the areas where there's the most research in how simply having inputs, right, does not translate into necessarily better use of those. So there's all these wonderful studies on soap and water, and yes, you need all of those things, wash, but the hands don't wash themselves. And so you see real discrepancies between availability of inputs and performance there. Some of the data we have in the commission as well. And then, Malawi, yes, a colleague from Malawi. So, and the question around, how do you factor in worker scarcity and patient ratios, and as well as task shifting, right? I think your question, yeah. Yeah, so it's a real problem. Resources and few trained health staff are a real problem. And I think Malawi is one country that's invested hugely, for example, in expanding its health workforce numbers. We had a Malawi commissioner, so we learned a lot from her. And one of her observations is that the trouble with a drastic expansion of the health workforce is that quality and experience is diluted, because those nurses or doctors, trainees, don't have the same time spent on wards, don't have the time with a mentor, and don't see the same number of patients and so on over time, because there's a real push to get them through. So I do worry about the pace of expansion. We need more health workers in every place. But somehow combining that with more experiential education and a deeper education, I think is really, really just as important. I would also say that I think task shifting works very well for some things, right? Absolutely wonderfully. I mean, I don't know of anybody better positioned than some of the health extension workers in Ethiopia or community health workers in Malawi or elsewhere who have the time to spend with families that doctors and nurses just don't have, and connect them to the system. That's a vital function. But what isn't, I think, effective, and I think actually there are data from a 3-country study recently on community-based management of pneumonia that suggests that people don't want to get their curative care, complicated care, from community health workers. They want to go to the system, especially increasingly as communities become more educated and connected and so on. So we have to be careful what we ask of some of these task-shifted folks, because often my experience is all our dreams and wishes land on the shoulders of the least trained, least paid, and often female worker in the community, and that's not right.
Do 1, 2, 3 over at the slide.
It's okay. Thank you. My name is Kanawan.
Use mic, please.
Okay, my name is Kanawan. I'm from Thailand. I'm a doctor as well, and also an MPP student this year. I have a question. In my country, we have implemented the universal healthcare coverage for almost 15 to 16 years, and it's bankrupting my country very much. And it's very difficult to say that to improve the quality of healthcare system, along with providing the UHC. Yeah. So what are your practical suggestions in order to do that?
Hello.
I'm glad you're asking me easy questions. Okay, go ahead.
Hi, myself Priya from India. I saw in one slide some parts of India were covered, but Odisha, Madhya Pradesh, and Haryana, they have a very high maternal mortality, but no data. It's not covered. Yeah. So can I know the reason behind why it's not covered?
Yeah.
Thank you.
Hello, my name is Aikarim. I'm an MPP student from Kyrgyzstan, a lower middle income state. And it has been mentioned in one of the clusters that one of the recommendations for improving healthcare systems is to foster the partnerships between different sectors. Yes. And there is a growing degree of evidence that multi-sector cooperation can actually lead to better health outcomes. Mm-hmm. However, those countries which experience which are lower middle income countries, how realistic do you think it is to engage the private sector, given that they are more concerned with the profit maximization as opposed to being engaged in these important causes? Thank you.
Wow, okay. I think these are questions for all of you. I'm happy to offer some early thoughts, and fortunately some of these are straightforward data questions I can answer. So UHC. I think there is a problem between political promises and reality on the ground in every country, by the way. But I think in low and middle income countries that have embraced the UHC agenda, in your country, I think you should be very proud, actually, of what has occurred. The declines in mortality in Thailand, unlike in very many countries, have been pro-poor for the most part, which is quite amazing because, as I showed in the inverse care law, the better care and the better services tend to find the rich first. And I'm not saying that's without qualification, but overall, on a population level, there's been a lot of incredible examples from Thailand. The question about how much you're spending and whether it's bankrupting the country is a political question of value. So now this is where we step back and we say, what do we, in this country, in our country, country X, want to spend on health? And one thing that I think is really crucial is that decisions should not be made in isolation. It should be made in conjunction with the decision of what do we spend on social services, what do we spend on education, and where can health complement. I am not the kind of person or the person who says universal health coverage is the solution to all our health problems. Far from. It is part of the solution, as I said earlier, and an essential part. People count on it. Nobody wants to be sick. Nobody wants to feel dependent, and yet we all need that assurance. I think the challenge in many countries is twofold. One is they're promising universal health coverage but not actually investing in the quality. And so therefore UHC is not universal health coverage, it's just a universal insurance coverage. And that to me is an insurance scheme, not a health scheme. So quality is the secret sauce that transforms insurance into health, right? The second is that the over-promises. I mean, they're saying, you know, yesterday we were providing some services for free for some people. Now it'll be free for everybody, but they're not any better. I think that is a real problem because it's going to leave populations disaffected. Mexico was a key part of our commission. That is a country that's achieved universal health coverage, right? And yet my Mexican commissioners and colleagues say all the time, we have huge out-of-pocket spending. Why? Because people don't use the insured clinics. They don't want to go there. They don't have the services, the timeliness, the customer service, the content of care. The essence of care is not there for them, and they're going to go private. And the same is true in other countries. So the point I'm making, I guess, is if you're going to invest in UHC, you better, you know, put quality right at the heart of that. Otherwise, you're not only wasting money in terms of, having to spend all this money, but you're not necessarily getting a health benefit, and people are still paying out of pocket. So it's just, they're a marriage. They're sort of an intrinsic whole that needs to be there.
Just a follow-up question, just a quick one. So we have been talking about the co-payment scheme.
Mm-hmm.
So what are your thoughts on that?
Okay, so I think we should, I'm happy to take some very specific questions maybe for a few minutes afterward, but I think there's a lot of interesting evidence around co-payments, and many systems use them to try to reduce unnecessary demand with only partial effect. But I want to come back to your question around data from the parts of India that really are the worst parts. Again, you're seeing the mismatch between where data are available and where some of the worst health needs are. We see this over and over in our work, right? Cardiovascular disease, a huge area of mortality. We don't have data for it. We only have data from a few countries. And so in New York, in the case of India, there we had data for those states that I showed, and unfortunately not for the others. And then there was one more question. Oh, yes. This is a really important point. You know what? I don't think we are living in the real world. Countries, in every country, the private sector has a different role, right? In my country, of Canada, my original country, most physicians are private contractors to the government. They're not employed, just like I think in the UK now, it's pretty similar. So private doesn't mean evil. Private doesn't have to mean always profit maximizing. Yes, there are people interested in doing well and making a profit, but there also is a commitment to high quality care in many of these countries. So I think it's really important to start with the system you have. And so, for example, I don't know about Kyrgyzstan specifically, but in many countries, India again comes to my mind, much of the care delivery is already in the private sector. So to say that we're only going to strengthen the public sector and hope, I don't know, these guys are just, beyond the pale and we shouldn't engage is not a workable strategy. You need all hands on deck. This problem is so big that it really does need everyone. And I think the issues of regulation, there are lots of tools to try to manage this. It's not perfect. Countries are struggling with it at every level of income. But there are ways. Now, there are ways to try to bring into the fold private providers.
Come over to this side. One up here, 2, 3.
Thank you for your presentation and really important findings and suggestions. My name is Yu Xuan. I'm a master's student at the School of Geography in Environmental Change and Management. I'm a former MPP student at BSG. Really interested in the system competent level at the global level, because you talk about empowering local doctors and how you use experience learning. But then what about brain drain, and what about like addressing those issues like in a global level? Just interested in learning that. Yeah. Thank you.
Okay.
My name is Ariana, and I'm an alum of the University of Oxford. I own 2 medical patents, and I deal with chronic diseases and treatment for chronic diseases here in Oxford. The issue of the quality, but not necessarily the quality of the whole healthcare system, but the quality of care and the quality of life. There are some interventions that are not necessarily benefiting the quality of life in the long term, and yet 50% of the global population lives with chronic disease. So how do we address the quality of life? How do we measure it in a way that is actually, an optimal way, and how do we incorporate this measurement into the overall assessment of the system quality?
You mean unnecessary care?
Unnecessary care
Okay.
that actually causes side effects and terrible side effects that have to be picked up by other healthcare practitioners.
Sure.
Here at Oxford. So my question is, some countries are now implementing the UK's or Canada's system where primary care practitioners are contractors for the government.
Yeah.
So do you think that this is a good model to be implemented in low middle income countries?
Okay, great. So let's take the, is that okay? Can we jump into, okay, great. So I think your question about brain drain is really difficult. I wish I've struggled and thought about that for a long time as well. I'm Canadian. I work in the US. So you could say I've brain drained myself or something. I've been sucked away or something. I don't know. I have a hard time with this one. And partly because I want people to be mobile. I think that everyone should be in the place that takes best advantage of their talents. And I will say that not too subtly, with all of my students, I say, please go back to your country. We love having you here, but could you? Because, right, that's where the impact is. But I don't know that, countries have tried, right? There have been compacts, and you know this better than I do. There have been efforts at policy agreements and so on. But fundamentally, when people see the opportunity to improve their lives, and very often to also have a meaningful say and a meaningful role in another country, they will go. They will go. And so I think it is absolutely critical for the sending countries to be thinking about that. We had a question earlier from one of your colleagues say, well, I want to go back to Nigeria, but what am I going to do with this new degree? That is a really important question, right, there you are, for Nigeria to contend with, because it's at risk of losing an incredibly important mind that could be helpful to the country. So it isn't just about the sort of the supply side or the demand side. Both have to be in concert. I do think there are ethical hiring practices that have to be followed. Those are without question essential. But I'm not sure that they've completely slowed the flow of providers, because there always will be gradients that people who are mobile and educated will follow. So that's not satisfying, but I don't have a great answer. This is a really great question, your question about too much care. I think for us, there's no distinction. Too little care or too much care is poor quality care. If the care is not indicated for the condition, then again, it's a waste of money. It's incurring costs for the patient as well as symptoms. Just before this trip, I was talking with my mother-in-law who got a chronic illness, and she casually reported to me that she was now put on a sleeping medication. She's never complained of sleeping problems, but one of her clinicians decided this was useful to add to her armamentarium of already, and my primary care alarm signals, started to sound. But just to say that, this notion of polypharmacy and unnecessary diagnosis and so on is just as much of a target in our minds as is under provision. Although in many of the lowest income countries, it hasn't come to that yet. And so that's where we focus most of our work. There's some really interesting work on something called right care. There was a series, in fact, in the Lancet 3 or 4 paper series that spoke about both sides of that continuum, and we're very supportive of that way of thinking. I think right care is what we want, not too much, not too little. It's the Goldilocks situation. And where was? Oh yes, right, contracts for government. Yeah, I think every country, again, should start with where it is today, right? I mean, in Canada, this system evolved as it has in the UK. There have been many models, physician fund holding and trusts and so on and so forth. What I would really love to see, rather than saying there's a single model, which probably isn't true, is some way to share good data and evidence on these various experiments, financing and provision experiments. In general, the received wisdom is that provision and financing, they're well to be separated. There's some benefit to be gained from being able to extract more out of contractors than perhaps out of employees with protections and so on. I think it's going to look different in every country. But I think what we do know is that having autonomy and responsibility and a clear accountability with all the pluses and minuses of that are essential. So however you end up providing care, those same elements need to be there.
We're out of time, I'm afraid, but I think Margaret can hang around for a few minutes afterwards and ask any questions if you didn't get a chance to ask them. So all that's left is to join me in thanking the staff of the Blavatnik School of Green Templeton College, Mike English, and of course, Margaret Kruk for a wonderful evening. Thank you very much.
Thank you.